Well, thank you very much. I want to thank the conference organizers and particularly Dr. Fouad for having me here. So I stand between you and lunch, and I'm hungry. So I'm going to try to go quickly, but I appreciate the chance to indulge you for 15 minutes just to tie together some of these points. The question was, what more is there? If there's nothing else that I want to leave you today, neighborhoods matter. And unfortunately, communities of color suffer one insult after another. It's not just food, it's not just housing, it's not just transportation, it's not just the quality of schools. It's all of these things. And so I want to see if we can quickly tie together some of these things. I don't have the solutions. The solutions are in this room, and they are with the residents of these communities. So I think it's very important that even though we've brought in these national experts, not a one of us, I think we would agree, holds the solutions. The solutions are in the community. So, what are the root causes of racial and ethnic health inequities? If we don't understand the root causes of racial and ethnic health inequities, we can't solve the problem. Racial and ethnic health inequities exist literally from the cradle to the grave in the form of higher infant mortality for African Americans, American Indians, and others, a higher burden of chronic disease and disability, again, for African Americans, Latinos, many other populations, and premature mortality. These are significant problems that affect every community, not just communities of color. That's the other major theme that I've heard this morning, which is very important. Our fates are deeply intertwined. The most advantaged communities will not prosper when some in our communities are not prospering. So why do we have, what are the causes of racial and ethnic health inequities? And how do we solve them? We need to know what those root causes are. Let me illustrate this with a brief story. It's about a friend of mine. I'll call him Dan. Dan has a dog who, like other dogs, likes to get into mischief every now and again. One day, Dan's dog brought home what appeared to be a dead animal in its mouth. I apologize for telling you this story before lunch. The animal was dirty and mangled. Dan gently pried his dog's mouth open, and to his shock, he realized it was his neighbor's favorite pet rabbit, Fluffy. So in a moment of panic, he shampoos the rabbit's fur, he blow dries it, and one day when the neighbor wasn't home, he sneaks the rabbit over there and puts it back in its cage. So a couple days later, Dan is talking to his neighbor, and the neighbor says, "I don't know if you knew, but my rabbit Fluffy died." Dan pretends like he's surprised and shocked, and he says, "You're kidding. How did it happen?" The neighbor says, "Well, he died of natural causes, but the crazy thing is some nut dug him up out of his grave, cleaned him off, and put him back in his cage." So we have to understand the root causes of health inequities to intervene. Otherwise, you're going to be digging up a rabbit that was already dead. Let me also try to tie together the theme of the economy and health. We've talked about the impact of the current bad economy on the nation's health, and one thing that we should be aware of is that this economy is going to cause health inequities to get wider. In other words, people of color are going to get sicker relative to national averages. It certainly can affect the nation's health as a whole, but health inequities are going to get wider, both on the basis of race, ethnicity, and socioeconomic status. But it's also true that health inequities, particularly as suffered by people of color, also drag down our economy. Okay? Right now, about 40% of the U.S. population under 17 are people of color. By 2042, half of us in the United States will be people of color. So again, our fates are intertwined. If we don't address the health inequities that exist for communities of color, not only will there be tremendous human suffering, but there will also be consequences for our economy. In the fall of last year, the Joint Center released a report that looked at the economic burden of health inequalities in the United States. In other words, what are the costs to society when we have persistent inequality in health status? We asked Dr. Thomas Leviste and some other distinguished scholars to estimate three things. One is the direct medical costs associated with health inequalities. In other words, because we have a higher burden of disease and disability and premature mortality among people of color, what does that add to the total tab that we're paying as a country for our healthcare costs? We asked them to also estimate the indirect costs of health inequities. So these are things like lost wages and productivity. What does it mean when someone's too sick to work? What does that mean not only for that family, but for the economy as a whole? And what are the costs of premature death? What are the costs for state and local tax coffers when people die before their productive years are over and can't continue to put that tax revenue into our coffers? What we found was pretty striking. Between 2003 and 2006, in that 4-year period, over 30% of direct medical costs for African Americans, Asian Americans, and Hispanics were excess costs due to health inequities. In other words, these were funds that we didn't need to expend because of the higher burden of disease and disability in these communities. Eliminating these inequities would have saved us nearly $230 billion in this 4-year period in healthcare costs. And in the same period, if we add in the indirect costs associated with lost wages and productivity, lost tax revenue, the total cost to the nation is $1.24 trillion. Now, we raised this in the context of the health reform debate that was going on because costs were becoming a preeminent consideration for the legislation. But this figure, $1.24 trillion, is higher than the cost of any bill introduced in the House or Senate in the context of the health reform debate. In other words, there's a high cost for doing nothing. If we allow these inequities to persist and widen, as I believe they are in the current economic downturn, then there's going to be a tremendous cost to the economy. So not only is there a human toll and a strong moral argument for correcting these inequities, there's also a strong economic argument. Okay, let me try to bring together, again, some of the conversation that we've heard earlier. In many respects, what I have to say mirrors what Dr. Bullard and Professor Cashin said. I'm tremendously influenced by their work and scholarship and others in the field, including David Williams and others, who argue that we need to be looking at neighborhoods. In the United States, we tend to think about health as being a product of individual behavior and health care. Okay, now those are important. Clearly those are important, but both are powerfully shaped by where you live. In fact, your zip code is more important than your genetic code in predicting your health. Once we begin to recognize that, we see that community empowerment is the core solution. So we know that neighborhoods have direct effects on physical and mental health based on what you're exposed to on a daily basis in your neighborhood. Environmental exposures, air, water, and soil pollution, polluting industries, stressful living conditions, crowded housing, dilapidated housing. All of these are direct influences on health and well-being. There are indirect influences on behaviors that have health consequences. It is now well documented in the literature that what is available in your neighborhood is what you will eat. And if you are an African American, if you have a grocery store in your census tract, you're 30% more likely to eat fruits and vegetables than an African American who does not have a supermarket in your census tract. There are health impacts resulting from the quality and availability of health care. But unfortunately in this country, we still have a phenomenon known as medical apartheid. Separate and unequal health care, in large part because of residential segregation, but also because of differences in insurance status. And there are health impacts associated with opportunity structures. So access to not only healthy food and safe spaces, but capital for building business, creating jobs. So all of the things that we've talked about today have health consequences, and believe me, the literature is clear. These are more important, increasingly more important, than things like access to health care, as important as that is. Segregation plays a powerful role in shaping all of these factors. In fact, David Williams calls segregation the root cause of racial and ethnic health inequities. In the United States, we tend to believe that segregation is a relic of the past. We have gotten beyond this. But unfortunately, many U.S. cities remain highly segregated. These are data from Doug Massey and other demographers who've looked at the levels of segregation in apartheid-era South Africa and have compared it to segregation in several major U.S. cities. They're using what's called the dissimilarity index, which is the percentage of people in a defined geographic area who would have to move to create integration in that area. So in South Africa in 1991, prior to apartheid being dismantled, the dissimilarity index was 90, meaning that 90% of white South Africans and black South Africans would have to move to create integration in that country. And unfortunately, several U.S. cities were not far behind this level of segregation. My hometown of Detroit, Michigan is one of the most segregated cities in the U.S. with a dissimilarity index of 85, meaning that 85% of white and black Detroiters would have to move to create integration in that city. I think it is no coincidence that the most segregated city in the U.S., Detroit, also has not a single major grocery store or supermarket within the city limits. Not a single one. What you have in contrast is an abundance of fast food, liquor stores, tobacco vendors, people selling things that are bad for you. Okay? Segregation tends to lead to disinvestment. And believe me, there are plenty of people in Detroit who can afford to buy groceries. Several other U.S. cities are not far behind this level of segregation. Milwaukee, New York, Chicago, Newark all have dissimilar indices of 80 or higher, meaning that 4 out of 5 people in these cities would have to move to create integration in those cities. A few years ago, with my former organization, the Opportunity Agenda, and the Poverty and Race Research Action Council, whose board Cheryl and I both sit on, did some research to look at trends in the share of poor families living in high poverty neighborhoods. We were interested in the question of whether the percentage of poor families living in high poverty neighborhoods had increased or decreased over the past 40 years. As Dr. Bullard pointed out, African Americans at all income levels are far more likely to live in a segregated neighborhood characterized by higher levels of poverty than whites at all income levels. Segregation restricts socioeconomic opportunity. What's the best predictor of your health status? Your education level. But to the extent that kids of color are enrolled in crumbling, failing schools with high dropout rates, teachers poorly credentialed to teach in the subjects that they're teaching in, outdated textbooks, we are setting these kids up not only for a trajectory that is a bad one for educational opportunity, but it's also a poor trajectory for health. African Americans are 5 times less likely than whites to live in census tracts with supermarkets and are more likely to live in communities with a high percentage of things that are bad for you for sale. Black and Latino neighborhoods have fewer parks and green spaces, fewer safe places to walk, jog, bike, or play. The list goes on. You've heard all of this morning. Communities of color are more likely to be exposed to environmental health hazards. This has been demonstrated in a large body of research, much of which Dr. Bullard has contributed to. The United Church of Christ study, 2007, was it replicating the study from 1987, finding a disproportionate burden of environmental health threats, polluting industries, et cetera, in communities of color. And then there's the poverty tax. People who live in poor communities have to pay more for basic goods and services. Do you ever try to get auto insurance in an inner city community? You're going to pay more for auto insurance than you would in the suburbs. You're going to pay more for basic services, bank fees, if you can find a bank. Okay, that's the other problem. A lot of these communities don't have a bank. Instead, you have check cashing outlets. Again, it restricts socioeconomic opportunity, which is a powerful predictor of health. I apologize for those of you who are hungry. I'm going as fast as I can. What does the evidence suggest? We now have an evidence base. Sure, more research needs to be done, but we know enough to begin to act. We know that we need to have a focus on prevention, particularly on the conditions in which people live, work, play, and study. We need multiple strategies across an array of sectors. I heard that this morning, and I want to just strongly second that. This is not just a problem for public health. We need our business leaders, we need our faith leaders, we need our educators, our community groups, our grassroots groups, all working to solve the problem because we are all stakeholders in this problem. And we need a sustained investment and a long-term policy agenda. These problems took 300 years to create. We're not going to solve them in 5 years or 10 years. But unfortunately, our elected officials are often looking at the next election cycle. So they're looking 2 years down the road, 4 years, 6 years down the road. We need the political will and the sustained commitment to working on these issues over a generation or more. So there are 2 general strategies that we try to focus on and promote in our work at the Joint Center. One are place-based strategies, increasing investments in communities. There's now a very strong appreciation at federal, state, and local levels that there is a role for government to help lead and to stimulate investments. We were talking about grocery stores. Commonwealth of Pennsylvania started a remarkable experiment, the Fresh Food Financing Initiative, creating tax incentives for grocery stores to locate in food deserts. Their experience was that these grocery stores achieved a so-called triple bottom line. Not only did these stores improve access to healthy foods in these communities, but they also created jobs and they turned a profit. Okay, but it took those tax incentives and other policies around land use and other kinds of policies to create the appropriate incentives for those grocery stores to go into those communities. There's now a federal fresh food financing initiative modeled after the Commonwealth of Pennsylvania's work. Secondly, there are people-based strategies, increasing housing mobility options to deconcentrate poverty and allow folks who want to move out of communities that suffer from disinvestment into higher opportunity neighborhoods. I don't have time to go into detail on these, but I just want to offer our experience at the Joint Center through an initiative called Place Matters as one model for how we can begin to mobilize some of these strategies. At their core, these efforts are about community empowerment. It's about community empowerment and elevating the voice of communities to effectively engage in the policy process and successfully get the kinds of policies, programs, and practices that they need for good health. So our effort is to build the capacity of local leaders to identify and address what we call in the public health world social determinants of health. I actually don't like that term because most people don't know what social determinants of health are. We're talking about neighborhood conditions that shape health. We're talking about the quality of your housing. We're talking about the quality of transportation, jobs, food, schools. All of these things are social determinants of health, and they're very powerful. We're trying to engage communities to increase their capacity to advocate for evidence-based solutions. We're measuring our progress, and we're trying to build a national learning community so that we can share best practices. One of the things that we know through the work of community organizers and others is that when you've seen one community, you've seen one community. No one size fits all. But again, at the core, it's about trying to elevate the voices of folks who know the community best. And often, this work builds upon sources of resiliency and strength in the communities that we're trying to work with. That's something that we can't emphasize enough. We talk about the problems in these communities, but I think there needs to be a much richer appreciation for the fact that many of these communities also have many strengths and resources that they bring to the table that can solve these problems. So we're driven by a model that looks at the intersection of health, place, and equity. And place very much correlates with race so that we can enter into a conversation about race. We're talking about the quality of health facilities, schools, and childcare, community safety, transportation, work environments, parks, housing, access to healthy food. All of these things are often determined by place. So we need to look at the intersection of environments, health, and equity. Equity has to be the thread that runs throughout all of our work. We're not trying to take from one community to give to another. We're trying to create equitable conditions for good health for every community. We're working in many different communities around the country. I'm proud that we are working here in Jefferson County with a team led by Congregations for Public Health, Reverend Ronnie Williams and his group. This team is focused on trying to address the childhood obesity crisis by doing a number of things, including trying to ensure that kids have access to appropriate physical education in schools. One of the things that's important about this initiative is that we're not just in urban areas. Correctly, we have focused some of our attention on rural communities. So we are also working in Mississippi, in the mid-Mississippi Delta and the South Delta, and in the San Joaquin Valley in California, where there are tremendous issues around place. We are concerned, for example, for migrant farm worker communities who often live in unincorporated communities that may lack power, running water, basic things that we take for granted. They live in third world conditions, and that's obviously bad for health. Let me just conclude with this quote, and I like it because it shows us that we have the power to change these conditions. This is from the World Health Organization Commission on the Social Determinants of Health. They wrote in 2008 that inequities in health and avoidable health inequalities arise because of the circumstances in which people grow, live, work, and age, and the systems put in place to deal with illness. The conditions in which people live and die are in turn shaped by political, social, and economic forces. In other words, we have the conditions that we've been talking about this morning because of the choices that we have made as a society, because of the choices that our elected officials make. We have the power to undo some of those choices and implement policies and practices that have equity and place as a key goal to ensure that everybody has an opportunity for a healthy life. Thank you, and I hope that I didn't take too long so we can enjoy our lunch. Okay.